Good morning. This is Dr. Moscato of Missouri Cancer Associates, and I wanted to talk today about AML, or acute myelogenous leukemia. The presentation is generally that of pancytopenia, which is quite common, although you can have a high white count with anemia, and thrombocytopenia, weakness, bruising, and infection. Bone pain is relatively uncommon in adults, and rarely there are extramedullary sites such as skin, gingiva, epidural sites, and these are called chloromas or granulocytic sarcomas. Now, the history is important in AML. There are really two kinds. One is secondary AML with a worse outcome, and this comes from prior myelodysplastic syndrome, prior chemotherapy and radiation, and it's often associated with poor cytogenetics and poor outcome. And then there's what we call de novo AML, which arose without a pre-existing illness. This often occurs in younger patients and has a better prognosis, although either can occur at any age. Now, the important points in history that you want to talk to the patients about are those things which would be important in terms of treatment and problems with therapy. First, a history of CHF would preclude anthracyclines, which we usually use, and will also, of course, lead to fluid overload problems with all the blood and platelets and fluids and antibiotics that are being received. Multiple prior transfusions may make cross-matching difficult. Drug allergies are important, and you often will see an allergy to allopurinol present during induction. Prior herpes infections and active menstruation may be a problem, and it may need treatment to stop menstruation. Now, the physical examination you want to pay attention to every day when you see the patient. You want to look for pallor. Infectious embolic lesions are especially important. These would be nodular lesions, which often occur on the extremities, can be mildly erythematous, may be painful or not, but maybe something we would want to biopsy for a source of infection, so point those out. Rashes in general, open lesions which are a source of infection, and leukemic lesions may arise. Now, poor dentition is often a problem. These patients present acutely and need treatment, so we really can't send them back out to the dentist. So mouth care is really important, but poor dentition is a significant site of infection. In AML, organomegaly and joint pains are unusual, although they can be seen. Now, in the laboratory, the CBC may show pancytopenia or leukocytosis, along with anemia and thrombocytopenia with blasts in the blood. However, you don't have to have blasts in the blood to have AML. They may only be in the bone marrow. It's critical to look at the uric acid, the creatinine, liver functions, phosphorus, and the LDH, which is usually up, but not so markedly as in ALL or Burkitt's lymphoma. A bone marrow is usually done to define cytogenetics and flow cytometry, but if there are enough blasts in the blood, we may not need to do that and just do the testing off of the blood. Now, you'll hear us talk about FAB classifications of AML. There's M0 through M7. M0 are blasts with very little maturation or none, as M1 has some differentiation. Now, the most important one of this to distinguish is M3, or promyelocytic leukemia, because that one particular kind is treated much differently. And for those, you'll see us use often more anthracyclines and ATRA, or all-trans-retinoic acid, and then arsenic in consolidation. So it's treated very differently from the others. As we go up to M4 through M7, we have more maturation of different types and often worse outcome. Now, cytogenetics are chromosomal changes that are critical for prognosis. At this point, they have little impact on induction except for the APML, which we talked about, with the 15-17 translocation, which is treated quite differently. Cytogenetics, however, are important for post-induction therapy and prognosis, where choices may be high-dose Ara-C as consolidation or moving right ahead to allogeneic stem cell transplant, especially if the patient is younger and has a SIB. Now, when we look at cytogenetics, we look at risk factors, favorable, intermediate cytogenetics, and good cytogenetics, and you can see, in adverse cytogenetics, and you can see that the outcome in terms of overall long-term survival is very different for the three groups. So it really makes a difference, and you can see why we move toward transplant in those with poor cytogenetics. Now, the prognostic factors are good and poor. Now, I put good in quotation marks for a very important reason, because nothing about this disease is good. As you can see, the long-term survival, even for good prognostic factors, is still only 50%, except in APML. But young age is helpful, very helpful. Inversion 16 or T821 is important. Rapid achievement of remission. Now, the APML, or the T15-17 translocation, has a much better cure rate. It approaches 80%, and it's treated very differently. Core binding protein is, I wouldn't say exactly experimental, but it is still uncertain how to use that, but it is a better outcome. Poor prognosis is age greater than 50, unfavorable cytogenetics, and LDH greater than 3 times normal. Other new prognostic factors include FLT3, NPM1, KIT, and gene expression profiling, all of which at this point are still research studies. Please go to the second video, AML Part 2, Treatment. Thank you.